The year 1866 was signalised by a remarkable incident, a mysterious and puzzling phenomenon, which doubtless no one has yet forgotten, not to mention rumours which agitated the maritime population and excited the public mind even in the interior of continents. Seafaring men were particularly excited. Merchants, common sailors, captains of vessels, skippers both of Europe and America, naval officers of all countries, and the governments of several states on the two continents were deeply interested in the matter. For some time past, vessels had been met by an enormous thing, a long object spindle-shaped, occasionally phosphorescent, and infinitely larger and more rapid in its movements than a whale. That is the opening to Jules Verne's seminal work of science fiction, 20,000 Leagues Under the Sea. And unfortunately, the enormous thing was not lung cancer, it was not ALK mutations, but I think carries a similar sentiment because this is the first episode, as mentioned at the end of our last episode, our interview with Ash. If you haven't listened to that, please go back and listen to it. That we are entitling, or that I'm entitling unilaterally, Josh has had no say in this, 20,000 Leagues Under the Lung Cancer. In this series, we are going to talk about non-EGFR mutations. We've spent a lot of time talking about Adora and Flora and all of the other auras, but we're going to talk about some of the others, give them a chance in the limelight. Josh, how are you going? I hope you enjoyed my introduction of Jules Verne, who I don't think has ever been associated with oncology.
Michael, you never cease to amaze me with your esoteric introductions, but I think I got to 20,000 Leagues first, so I'm pretty happy. It was in one of our prior episodes, and I was Captain Nemo for that episode. It was beautiful.
Yes, you do a good Captain Nemo.
Thank you.
Yes, you're very good at going mad right at the end and disappearing into the ocean. Spoilers.
That's the end. It's been a very long time since I read 20,000 Leagues Under the Sea. Oh boy. Shall we get cracking on this week's episode?
Yes, please introduce the first mutation that we're going to talk about, and we're going to spend an entire episode on it, which is ALK mutations, Josh, as we dive down beneath EGFR and into the subterranean
through the bronchi, into the bronchioles, and the parenchyma that is the lungs. ALK, anaplastic lymphoma kinase. It's a tyrosine kinase known to be expressed in multiple tumor types. In non-small cell lung cancer, our topic today, you find that in about 3 to 5% of tumors. Now, detecting ALK gene rearrangements is paramount to treatment. Why? Stay tuned and you will find out. So there are some unique clinical features for ALK tumors. So brain mets are more common in ALK-positive non-small cell lung cancers compared to those who lack it, or EGFR inhibitors, mostly in patients that have never or lightly smoked and a younger age, about a median age of 52, although not always guaranteed. Like everything in medicine, nothing is guaranteed. The majority of patients with ALK mutations have adenocarcinoma rather than squamous cell carcinoma, although there's a small amount that can be squamous cell carcinoma. I feel I'm just covering myself, Michael, with everything I say. It's mostly this, but there's always a chance of something else.
I'm sorry, did you just describe medicine as a whole?
Yes, and oncology. So you need molecular testing for the diagnosis, and that's really the starting point of any lung cancer. And the question you're then going is like, I have a mutation. Do we have something to target this? Well, this is the episode where you get to find out. First, you assess for ALK. Second, you realize that first generation TKI crizotinib is not particularly good, with the phase 3 data showing prolongation of PFS, objective response rate, and quality of life, but no overall survival data with a hazard ratio of 0.76, but not statistically significant. But that was confounded due to crossover. And then you're like, what do I go? Where do I go from here? And you go to the second generation ALK inhibitor, which Michael will now explore.
Sometimes I think these drugs are like iPhones. You know, your first one breaks or the battery starts to die, and you just go to the next one. Before I start my study, Josh, I do want to come back to something that you noted, which is the commonality of brain metastases. And this is a clinical point. I don't know if it's the same in your center, but in my center, so if someone has a complete response or they're on treatment and they're responding, it is not always the case that we image their brain as part of their standard follow-up if they are known to not have brain mets or if they're not known to have brain mets. However, with ALK, it doesn't matter if they've been in CR for 10 years or whatever. We always tend to do at least a CT, frequently an MRI, every time we quote unquote restage or rescan them. Is that your practice as well, Josh?
We do lots of MRIs because they can always be asymptomatic and potentially treated. So, yeah, we do it a lot. I haven't seen many ALK rearrangements. I've seen maybe a handful, if that. I've seen far more EGFR mutations in my center where we do regular MRIs, but I guess most of the time with patients who are on this treatment, they're metastatic, right? So, you're always going to be doing MRIs to check and make sure there's no disease progression.
That is true. Although, yeah, I will say that it feels very odd to be ordering MRI brains on someone who's had a CR, a complete response for years and years. Anyway, CRs are fortunately a not uncommon occurrence with Alectinib.
Much like subscribing to our podcast and leaving a review.
Yes. Okay. Josh has fulfilled his contractual obligation, and so he'll go. He'll leave now. But Alectinib is an agent, an anti-ALK tyrosine kinase inhibitor, that was the focus of the ALEX study, published in 2017 in the New England Journal of Medicine, with an update in 2020. At the time, as Josh mentioned, first generation TKIs were the standard of care for patients with ALK-mutant non-small cell lung cancer, the main one being crizotinib. The median PFS with crizotinib is about 10.9 months, which is good for non-small cell lung cancer, but Alex will do unto crizotinib what osimertinib has done to alatinib and gefitinib, that is, render it extinct. Alex is a phase 3 open-label randomized controlled trial that compares alectinib with crizotinib in the first-line treatment. 303 patients were randomized 1-to-1 to receive either alectinib or crizotinib, with the eligibility criteria being greater than 18 years, ECOG 0-1, treatment naive. Patients were allowed to have brain mets so long as they were asymptomatic, and notably, they were also allowed to have leptomeningeal disease, which is the textbook exclusion criteria for the vast majority of studies that you will see. They were also allowed to have previous radiotherapy if it was completed more than 14 days prior to enrollment. Patients were stratified on the basis of ECOG, race, whether they were Asian or non-Asian. ALK has a very high incidence in the Asian non-smoking population, and the presence or absence of CNS metastases at baseline. Interestingly, crossover was not allowed, but speaking of covering ourselves, Josh, the authors did a cheeky little bit of covering where they said in countries where Alectinib was already available, some patients might have received Alectinib, but it wasn't us, we swear. The primary endpoint for Alex was progression-free survival, with the secondary endpoints being time to CNS progression, overall response rate, overall survival, duration of response, the rate and duration of CNS response, and safety. In terms of demographics, brief notes on these as always. The median age, Josh, you hit it on the head in your introduction. 54 in the alectinib arm versus 58 in the crizotinib arm. The majority were female of non-Asian descent, but only about 54 to 55%. Majority were also non-smokers, and about 40% in both groups had CNS metastases at baseline. So in terms of the results for Alex, now it's important to note, as a previous take of this episode failed to mention, is that there is a difference between ALEX, which is the worldwide study of alectinib, and J-ALEX, which is the study of Japanese patients with alectinib. So we're talking about the final published results for the worldwide ALEX study, which were published in 2020. The median duration of survival follow-up was 37 versus 23 months. The progression-free survival was 34.8 versus 10.9 months, with a hazard ratio of 0.43. And this was higher regardless of the presence or absence of CNS metastases. At 4 years, 38% of patients with CNS mets at baseline upon entry to study in the alectinib arm had not progressed. And the median progression-free survival in patients with baseline CNS mets was 25 versus 7.4 months, so significant benefit in progression-free survival. In terms of overall survival, now this was actually not reached in the Alectinib arm versus 57.4 months in the crizotinib arm. Now, I should take a slight detour here and make note that the J-ALEX study did not actually demonstrate a 5-year overall survival benefit or overall survival benefit of alectinib compared to crizotinib. It should be worth noting with those particular results, without going into too much detail, that 82% of patients in the crizotinib arm subsequently got alectinib. And so there is some debate about how much success of crizotinib was basically being propped up by alectinib. But the 5-year overall survival rate in the global ALEX study was 62.5% versus 45.5%, which was consistent across subgroups with the exception of patients who were ECOG2 and patients who were active smokers. But there was about 20 patients in both of these subgroups. And Josh, I know you're going to set some hazard ratio records later in the episode, but how's this for a confidence interval record? For patients who are ECOG2, of which there are about 20, the confidence interval for hazard ratio was something like 0.38 to 10. So it could be 60 or 70% better, or it could be 1000% worse if you are ECOG2.
I'm going to say they had zero confidence in looking at that result.
Yes, absolutely. The p-value was probably also 10. In terms of the subsequent therapy for the alectinib arm, patients received crizotinib 13% of the time, lorlatinib, coming up to the CROWN study that you'll describe, Josh, 13% of the time, brigatinib, and ceritinib were also noted. In terms of safety, this was similar across both groups, with the rates of grade 3 to 5 adverse events leading to dose reduction, interruption, and treatment discontinuation, similar across both groups. The most common adverse events in the alectinib arm were constipation, fatigue, anemia, hyperbilirubinemia, myalgias, and AST-ALT derangement. So in terms of conclusions for the ALEX study, I mean, we've got this J-ALEX overall survival data hanging over our heads, but would we still give alectinib over crizotinib? Absolutely. I mentioned before that alectinib has done unto crizotinib basically what osimertinib has done to the earlier generation EGFR TKIs. There's now no reason to do it. Alectinib has good CNS penetrance, the toxicity appears to be well tolerated, and there's no reason to give anything other than alectinib at this point in the first line setting. However, Josh, is there a challenger seeking to unseat the newly crowned king?
More of an intern than a challenger.
A secretary.
Well, let's be honest. We're all a bit of a secretary.
A court jester.
A court jester. I have great secretaries and I don't want to kind of degrade them. So sorry, all the interns and secretaries out there. You're both wonderful.
And court jesters, you're also wonderful.
That too. I have a court jester on tap whenever. But I am talking about, yes, the underdog, the contender, the hazard ratio king or queen, potentially, lorlatinib. Is it the law? Not just yet, but it might be soon. It is a novel third-generation ALK inhibitor and has the broadest coverage of ALK-resistant mutations that has been identified. Michael, I remember seeing this picture, and I will link it on our website, of all of the ALK mutations that it actually does cover, and it is a lot more than brigatinib, alectinib, crizotinib, ceritinib, michaelinib. No, it's just Michael. But it's really interesting. It's also been designated to have really good blood-brain barrier penetration, which, as Mikey so eloquently put, is really important. No comment?
None at all. I'm just basking in your assessment of my eloquence.
Thank you. Well, you guys can be the judge of who is going to take the crown with today's episode. But the trial is called The Crown, and it was a randomized global phase 3 study comparing lorlatinib versus crizotinib, which at the time this trial was started was the standard of care. So you might take that into account. It's like, oh, why not alectinib, Josh? Alectinib is the new king. Well, because it wasn't around. at that point. And it was in those that were previously untreated with advanced ALK positive non-small cell lung cancer, and recruitment occurred between 2017 and 2019. Patients that were included was the standard ALK mutation, histologically confirmed, asymptomatic, treated or untreated brain mets were eligible, and ECOG from 0 to 2. Endpoint primary was progression-free survival via blinded independent clinical review, and secondary was progression-free survival via investigator, with overall survival, objective response rate, overall intracranial response, safety, and toxicity noted. The analysis was going to occur when 75% or 177 events of disease progression or death occurred. And the results were 296 patients underwent randomization, about half to lorlatinib, about half to crizotinib. The characteristics were quite similar to what Michael discussed. 44% of each arm was about Asian, and the other 50 was sort of white, and there was sort of a splattering of other ethnicities, you could say. Now let's look at the efficacy. So there's two. There's an updated analysis and an original analysis. So I think, Michael, I will talk about both because I have a bit of time. But you've got progression-free survival, so patients alive without disease progression. The initial analysis showed a median PFS not reached versus 9.3 in crizotinib, and the progression-free survival percentage at the 12-month mark was 78% versus 39%. So that's pretty nice number, and that's at 12 months, everyone. Survival without CNS progression was in lorlatinib. Well, the hazard ratio was 0.07%. Sorry, should not be laughing, guys, but the hazard ratio just blew me away. So hazard ratio for intracranial progression was 0.07. So it is 93% better than crizotinib.
I thought that was a p-value for a second.
No, that is a hazard ratio, and
that's the champion.
That's the crown, right?
That is the hazard ratio champion.
And the hazard ratio for CNS progression without previous non-CNS progression or death was 0.06%, so that's even better. And overall survival, was 0.72, but not statistically significant. So that's already kind of blew me away, just ridiculously good. And what you can see is that the confirmed objective response was 76% versus 58%, favoring lorlatinib. So already you've got a 20% benefit. You've got a complete response in about 3% of patients, a partial response in 73% of patients, and stable disease in 13%. So that makes it almost 90% of patients are going to respond with lorlatinib versus probably about 80% in the crizotinib arm, which is pretty just phenomenal. And that was kind of the initial analysis, everyone, right? So that's kind of the really exciting part. Let's go to the updated analysis, and then I will talk about everything else. So this was from September the 20th, 2021. Median duration of follow-up was 36.7 months. So median duration of response was 33.3 months in the lorlatinib arm and 9.6 months in the crizotinib. So just brilliant. What I note is that 30% of patients in the lorlatinib did have a dose reduction, and at cutoff, 33% of patients in the lorlatinib group and 63% of patients in the crizotinib group had disease progression by blinded independent clinical review or had died. When we're talking about PFS, again, it's still the median PFS has not been reached in the lorlatinib arm, and the crizotinib is still 9.3 months with a hazard ratio of 0.27, which is, that's osimertinib territory here. And if you're looking at specific numbers, what's the percentage of patients? So that's 64% of patients in the lorlatinib arm have not had any progression, and 19% of patients in the crizotinib arm had not had any progression. And that is 3 years. That is a 3-year mark. So just brilliant, bloody brilliant. Then if you look, I think that I just discussed there was the intention to treat population in those with baseline brain metastases. So this is what I'm talking about, progression-free survival now. What we saw was a median progression-free survival, again, not reached, versus 7.2 months in the crizotinib arm, a hazard ratio of 0.21, so slightly better than the intention to treat population. and the percentage was 50% of patients still had ongoing response and progression-free survival at that 3-year mark. Small numbers, so 37 in the lorlatinib arm and 39 in the crizotinib arm, but still quite incredible. And those without brain metastases, the hazard ratio was 0.29. Again, still the median progression-free survival was not reached. Michael, is there a theme? I think there's a theme.
The theme is very, very small hazard ratios, if I'm honest.
0.06, that is what I want to see. And so the 3-year progression-free survival, 64% of patients had not progressed, which is just incredible. If we do a dirty comparison to some other drugs, regorafenib had a median progression-free survival of 24 months, and then the PFS at 3 years was 43%, so 43% of patients hadn't progressed, and Alectinib was 46% for the PFS, with a median PFS of 34 months. Objective response rate intracranially was 83% versus 72% in the control arm. Now, I haven't mentioned this, but I will bring it up. Toxicities. There were toxicities, Mikey, and that's something important to note. So adverse events that were worse than lorlatinib and things that I think if you're treating with this drug, you should know: hypercholesterolemia, hypertriglyceridemia, edema, weight gain, peripheral neuropathy, and cognitive issues was 4 or 5 times more that of the crizotinib arm. And if you look at the crizotinib, what was worse? The classic TKI adverse events. So diarrhea, nausea, vision, vomiting, ALT increase, anorexia, and dry mouth. What I found fascinating and why I bring this up is adverse events leading to dose interruption or reduction in lorlatinib. So dose interruption was 49% and dose reduction was 21%. If you look at crizotinib, really similar. So dose interruption 47% and dose reduction in 15%. Interestingly, fewer people discontinued lorlatinib than crizotinib. So despite having more tox, people stayed on it longer. So I have questions about duration of tox, severity of tox, and it's all there in the article. But when you look at adverse events, the grading and real life exposure is just two very different questions. So why is this not yet taken the crown, and what is the issue with this trial? So a couple of things. What I've spoken about, a lot of these were not intended analyses. So while we've got improved data, it wasn't actually the outcome that they were looking for in the updated analysis. So we don't have mature overall survival. And so that's a little bit hard. And if you look at the subsequent therapy, Mikey, 22% of lorlatinib and 70% of crizotinib received at least one systemic anti-cancer therapy. The main reason for discontinuation in lorlatinib was disease progression, and 27% was other reasons. With other treatments received, lorlatinib was crizotinib. They actually switched it, and that's quite interesting. And in the crizotinib, they went to lorlatinib and some other sort of alternative TKIs. So very exciting. Still needs some updated analysis on this particular drug, much like Alectinib, Mikey. I don't know. Maybe it will fall flat. It doesn't look like it's going to fall flat. These numbers are, I'm frothing. I'm just like shaking in my boots, like Puss in Boots. I'm Antonio Banderas when he wasn't cool. No, he's always been cool. What can I say?
Absolutely. There's no universe where Antonio Banderas is not cool. I completely agree with you, Josh. This lorlatinib is something that is sort of lurking in the shadows and will be very interesting to see its final analysis.
Oh, one thing before you finish off, Mikey, I forgot to mention. You might be asking, how do you then rationalize what do you start with and what drug do you move to? So when doing some bit of research, they still recommend Alectinib as the first line, and then if you progress on Alectinib, move to lorlatinib rather than the other way around. And crizotinib, I think if you're in a country that doesn't have either of these.
And I think that's the current state of practice for as long as we don't have overall survival data for lorlatinib. So, Josh, that concludes our initial dive. We're currently at 10,000 leagues under the lung cancer, but would you like to tell us what we're going to do as we dive deeper into the darkness?
I feel this is too soon, but I really don't want to get into a submarine. I think I've decided that at the end of this episode.
That's not topical or anything.
No. So next week we have something even crazier. We're going 50,000 leagues under the sea. We are going to meet the Loch Ness Monster and
The giant
I don't know,
squid is the famous one.
the giant squid, and we're going to find the lost city of Atlantis is part of that journey. But we're going to look at ROS1 and KRAS mutations and the new and upcoming targeted therapies in this cohort. Michael, I just love this. Like, our future is going to be targeted therapy for patients who never had any options going back 3 years. So 3 years ago, you really had pretty much nothing, and now you have treatment options, and it's just so brilliant. Anyway, so I'm really excited. I'm not excited to get into anything that goes 10,000 leagues under the sea, but I'm excited to read about it. And as such, I look forward to joining you then.
We'll see you next week. Thank you for listening to Oncology for the Inquisitive Mind. You'll find previous episodes on our website, along with weekly posts, resources, and links to our Twitter and LinkedIn pages. Check it out at inquisitiveonc.com. That's inquisitiveonc.com.